Hi, so we'll make a start then. Welcome to today's ePrescribe Masterclass. I'm Amna Patel, Chief Pharmaceutical Officer Clinical Fellow at NHS England, and I'll let Hoyan introduce herself as well.
Good afternoon, everybody. My name is Hoyan Senya. I'm also one of the Chief Pharmaceutical Officers Clinical Fellow, both working for NHS England this year.
So today's Masterclass, we've actually got 3 speakers, which is really exciting to see. And in terms of the purpose of these classes, it's the monthly webinars to help NHS organisations share their learning and experiences of digital transformation to help support others. So what the platform aims to do is to break down silo working, kind of create a community and a network to enable trust to learn from one another. So just in terms of the overview of today's session, like I said, there's 3 speakers that we have today. At the end of each presentation, there'll be an opportunity to hopefully ask questions. Please use the question box, which is in the panel, which should be on your screen. There's no mic on this, so if you could just put your questions in there, they'll be answered either in today's session or at the end and emailed out if they aren't answered. Also, you'll get a certificate of attendance, which will be sent out after the webinar. And if there is a topic that you would like to present on, please do get in touch with Sarah from the network, and she'll be able to pass your details on to join a webinar in the future. So our first speaker today is Paul Wright, who is a standards implementation and engagement lead and is a pharmacist by background. And he also is the pharmacy terminology at TSAS, working in the Transformation Directorate at NHS England. And Paul's session will be on the DMD Plus and SNOMED CT terminology updates. So at this point, I'll hand over to Paul.
Thank you.
So maybe to notice Paul's webcam is not working, so yeah.
Thanks, Amna. Thanks, Hoyan. Can you hear me okay?
Yes.
Great, okay, great. Good afternoon, everyone. Hi. Yeah, I'm Paul. I work in pharmacy terminology and also across the digital medicines programme in NHS England. And I've just asked for a couple of minutes on today's session to make you aware of 2 consultations that are either shortly going to take place or are currently active. One's about the DMD and the other is about SNOMED CT. Next slide, please. Thank you very much. So I have previously attended these sessions to give the Masterclass community updates on changes that we make to both the DM+D and SNOMED CT UK drug extension terminologies. I just wanted to provide the group with advance notice that we'll be shortly circulating a survey and with that an accompanying test file so that people can assess the impact to the DMD as we're looking to update the scope of the DMD standard, which is the SCI 0052 standard, and the resultant changes to that, to the DMD files and download processes. So this is looking at impacts to technical changes. So our expected time frame for uplifting or updating the SCI standard isn't until 2025, but we want to get an early understanding from users of the impacts to help us plan and also look at what mitigations we can put in place to minimise impacts. So just to give you a bit of an understanding, at the moment, in addition to the main DMD file that's created, there's also a set of supplementary files, or bonus files as we call them, that are available. Now, the data in the supplementary or the bonus files, they sit outside the core data model and the core DMD download files. And the core download files reflect what is approved in the SCI standard. So anything out of the standard can't be released in the core files, in the core model. And the purpose of uplifting or updating the Sky standard is, as we have and continue to make changes to the content in DMD as a result of the enhancements that we talk about, we want to make sure that we reflect these changes as part of the core DMD data model and therefore as part of the standard. So the scope for uplifting or updating the DMD standard is on the screen. So we've already made available the DMD historic codes. They're already available as a bonus file. But in this year, we're also wanting to add ingredient information at VTM level, and that's expected later in 24, and also trade and trade family group, which are currently unavailable in SNOMED. But again, we want to make those available in DMD. And they would naturally go in as supplementary files, but this is around bringing them into the core model and the core files. As well as those additional information, we did remove excipient information in DMD back in 2022. Now, there's a table that exists and it's empty, so it's not doing any harm or anything, but as a tidy up process to all this, we want to remove it. So there's something that's coming out of the data as well. So this survey and this test file is to understand what impacts that will have on organizations, and that could be to your own organizations or to customers or users of the system. It could be to third-party integrations, it could be to any processes or documentation or anything in your organization. So this survey is going to be coming out. It's a short survey. We expect it to only take 10 or so minutes to complete, and we'll be running the survey for about a month or so for people to have a chance to feedback. So I'm hoping it's going to be ready kind of the end of this week. It might be early next week, but when it is ready to go out with the file, I'll get it circulated through the Masterclass community, so you can have a look at it and share it on with any colleagues that it's relevant to. So yeah, if you have any questions about that, please post them in the chat and I'll monitor that. Alternatively, if you think of anything at a later point, then there is the email at the bottom of the slide that will come through to the project team working on this, and we can answer anything for you. Next slide, please. Thank you very much. So that's the DMD, and then there is also one running at the moment, and this is related to users of SNOMED CT. So as well as my pharmacy terminology role, I also have a role working with SNOMED International, and NHS England is the National Release Centre for SNOMED CT for the UK as well. So that's kind of why I'm presenting on this. So SNOMED International are proposing to increase the maximum length of their fully specified name and synonym descriptions, which currently is at 255 characters, but they're looking to extend it to 4,096 characters. Now, the reason for that is that reflects the maximum length in their particular file specification. This is a proposal that has come from SNOMED International. This hasn't come from the UK. Now, within the further information that's available, there's a whole document that provides all the background to this, the decisions around the proposed change and the character length changes. And SNOMED have also provided a test file, again, available for people to use and look at what impact this is going to have to them. And within the survey that's available to provide feedback to SNOMED International, there's an opportunity for people to ask questions, and we can relay those back to SNOMED International and get answers to those for you. Now, the main intention for the change is so that implementers are allow for the maximum description character length. It doesn't necessarily mean that there's going to be lots of content going into SNOMED International with character lengths greater than 255. That's expected to be the exception. But they're basically opening up the character length to allow for it. Having said that, there is an example in a latest or the latest release of a New Zealand extension, which is expected to have a concept with around 331 characters. So I think SI or SNOMED International are thinking there's likely content which will be applicable to international use going forward in the future, you see. So they have allowed quite a decent length of time for a deadline, the 31st of July. Now, the UK is going to be one of nearly 50 member countries for SNOMED International who are going to feed back on this proposal. So SNOMED are going to have all this feedback, and they're going to have to formulate what it means and when they're thinking of what decision they're going to make and when they're going to make it. My understanding at the moment is they are targeting the January 2025 release to make this change. I'm aware also, obviously, for people thinking about DM&D, DM&D itself has character lengths as well. Now, those who purely have a DM&D system, as it stands, this will not have any impact on DM&D. We're not planning to make any changes in DM&D due to this proposal. So I just wanted to make people clear on that point for anyone wondering about DM&D. So if you can go and provide feedback, there's a form in there in the link, and that would be great. So that was all from me. I'll hand back to Amna and Hoyan, and I'll just monitor the chat for any questions. Okay, thanks very much.
Thanks, Paul. Paul, do you have time to answer the question that's in the chat box, or would you want to answer it after Joe's session?
I can have a look at it now. I can just see, I can only see part of it. Is it just displayed in digital systems ? Is that the question?
It's about the slides, I think. Sharing the slides.
Sorry, there's two questions. The slides will be after, yeah.
And then the SNOMED question is the SNOMED description limit increase, and it was asking about have we any feedback from suppliers of how these descriptions will be displayed in digital systems. That was the question from Anna.
Okay. So SNOMED International's understanding around this proposal is that with the community, with their advisory groups that they work with, is that user interfaces generally displayed the preferred terms rather than the FSN, which is the specified name. Sorry. So there's low expectation on longer descriptions breaking any current display formatting at the moment. That's the current understanding. But obviously, if there are impacts to displays, user interfaces, then that needs to be part of the feedback that goes back into SNOMED International from UK users. Yeah.
Well, thank you, Paul. And thanks for the presentation. And like Paul said, if anyone does want to get in touch, the slides will be sent out with the contact details. So please reach out to Paul and his team. So now we're going to move on to our next speaker today, and that is Graham Kirkpatrick, who will be presenting on how can ePMA systems support improvements in safety. And Graham is the head of patient safety advice and guidance at NHS England. I'm going to hand over to Graham.
Lovely, thank you very much, Amina. Next slide, please. So I did come here about 2 years ago. So this is just a further update on some of the new and the under recognized patient safety issues that we pick up as part of our work in the National Patient Safety Team. We have a number of mechanisms that we can use to take forward some of the insight that we gain, whether that's through networks such as the medication safety officers or through this forum. We obviously work with partners and try and work through some of the issues there, including the ePrescribing project, which I'll come back to at the end of my slides, and we can also issue a national patient safety alert. And like I said last time, these sessions are just trying to share some of the insight that we've gained and maybe challenge you a little bit about what the ePMA systems can do to try and improve things at the front line. Next slide, please. So the first issue, I think, for those who have been a regular attender at these meetings, I think there was a presentation either last month or the month before about the ongoing issue with confusion between penicillin and penicillamine allergy status. So we picked this up and we've been doing a bit of work on it in the background. It would appear as if there's two underlying issues that have caused this confusion. One is specific to the System C, L-Sky, JAC type system where they do the allergy sort of the way that they handle allergy status. They either have a drug name or a drug group fields, and if you search in the drug name for penicillin, you don't get it, because penicillin isn't a drug in and of itself, but you do get penicillamine if you just type in the first sort of 5 or 6 letters. So we think people are just picking the wrong one when that appears. So we have engaged with System C. They are working on a mitigation. They are going to make the warning alert much more prominent, and that will be in place by the end of the year, they say. But it is dependent on System C users upgrading to the latest version. So we're still working with them on that to see if there is anything else we can do on that. And then there appears to be a general issue with the other systems where, and this isn't just on allergy status, but if we're just using a drop-down list, obviously penicillin, penicillamine are in alphabetical order next to each other, and we think people are just picking the wrong one, which is relatively easy to do. So we're engaging with First Data Bank and NHSE colleagues to understand if there's any mitigations we can do to try and reduce that risk. So that's just some of the national work that we're doing. This could also be an issue in primary care, where the information gets sent through to primary care incorrectly and then is transcribed into the primary care systems. So we're just wondering to see what we can do about that. And so really this is just to make you aware of the underlying issue, the work that we're doing, and whether you need to consider about putting in any local mitigations whilst we try and work up any harder barriers at a national level. I know that some places run daily reports to pick up penicillamine allergy and then checking that that is valid or not. And in most cases, I suspect it would be penicillin that was the intended allergen, and so that gets changed as necessary. Next slide, please. Just a wee bit of an update on time critical meds. This is obviously a well-known sort of delayed and omitted medicines type issue that has been ongoing for ever. We know there's a specific issue around emergency departments, especially with the pressures that are currently being felt in ED departments and patients staying longer periods in ED. So we are trying to work on that. I thought I sent through some updated slides, but that's fine. Maybe that's me. So the in RChem, the Royal College of Emergency Medicines have issued a safety flash about time critical meds and are undertaking a QI project. So there may be some worth in your departments at least getting involved in that where possible. We did, like I say, 3 years ago, talk here about rasburicase in the sense of it being used for in conjunction with chemotherapy, but there is also the issue in ED when patients are admitted with tumor lysis syndrome, and we've been working with specialist pharmacy service to get some information out about the time critical use of rasburicase. So can you please have a look at that? But again, it's a challenge about how can EPMA systems try and support this work in terms of ensuring time critical medicines are given as soon as possible when they are required. So thank you on that. Next slide, please. Just some other issues that probably worth just raising. Some of these are fairly niche. So we did pick up an issue where a child was on insulin in a pump and went into a tertiary center to get that looked at, and when he came out he had a episodes of poor control, had to be admitted, took them a long time to get his glucose and his diabetes under control, and it turned out that his pump had been filled with diluting medium rather than the actual insulin. And to be fair, I've been a pharmacist for 30 odd years. I've never come across insulin diluting medium, but as you can see, the word insulin appears at the start of that descriptor. So there's something about when hospitals you trust are buying in specific items for maybe a one-off patient. How are they added to the actual EPMA systems? Should the word insulin appear at the start, we are speaking to the MHR array about that, but you don't necessarily need to put it on your system as insulin diluting medium if you assess that to be a risk. And of course, there is the issue that if it's being bought in for an individual patient, do you have a system in place for ensuring it gets taken off the EPMA system in some way, shape or form so that it is not apparent going forward unnecessarily and will reduce the risk of a LASA type error where staff are picking the wrong thing from a drop-down list. So that was that. Next one, I think, is Pen, is it? Next slide. Yeah. So we were made aware of an incident up here in the northeast where a trust confused benzyl penicillin sodium and benzathine benzyl penicillin and supplied their local ambulance trust with benzathine benzyl penicillin by mistake, and that got put into all the paramedics' carry bags. Which obviously was not a good thing. Thankfully, it was picked up relatively early and was dealt with, and everything was replaced. But there's not a lot we can do around lookalike, soundalike issues ourselves. Although we have spoken to colleagues such as Paul, where the DMD was just benzyl penicillin, it didn't have the actual salt. So we've now work with them to ensure that the DMD is now benzyl penicillin sodium, just to try and increase the difference. We've spoken to the BNF, who put something in about important safety information about the potential confusion, and not really a ePrescribing issue, but we have spoken to the Royal College of Pediatrics and Child Health, and they've confirmed you don't need to stock benzathine benzyl penicillin on any pediatric or neonatal wards. So we push that sort of messaging out via the medication safety officer network, but just bringing it here to just ensure that you check that your systems are clearly differentiating between benzyl penicillin sodium, benzathine benzyl penicillin, and procaine benzyl penicillin, just to try and again reduce the risk of confusion and mix-up. I think that's my last slide, but I do have one more issue. Can you just, thank you. So just one more issue around ePraise. So I will hope that most of you know what ePraise is. It's the NHS funded system that Newcastle are developing on our behalf, which can be used to assess the safety warnings in your EPMA system, whether there are too many, the right sort of level, or there aren't enough, and test for some critical issues. We are launching version 3 hopefully in the autumn of this year, and we are setting up a clinical reference group to try and work up some more test scripts and different scenarios, excuse me. So if anyone is interested in joining the clinical reference group. If you drop me an email, and I'll put my email address in the chat box, but if you are interested in joining, if you drop me a message, and I'll pass it on to the ePres team, who will be in touch if that is required. So thank you very much for the opportunity. That's all from me.
Hi, thank you, Graham, for that really useful update and presentations. There are a few questions in the chat box. I don't know if you can answer them now, but just one about it can be difficult to make clinical safety arguments with suppliers when there may be ways of avoiding the issue in the system. And the question is there a forum where issues which affect patient safety can be taken for an objective third-party opinion?
So I am very strongly of the opinion that we don't have enough levers with the system suppliers, especially from a national level, because they're all procured at the individual trust level. So I am working with colleagues within NHSE to try and work with them. They often have forums with the main system suppliers to try and work up some way of ensuring that the key safety improvements that we think EPMA systems could make are pushed out from us to the system suppliers, and that they will then try and put them in place in a timely fashion. But like I said at the start around the penicillamine issue, that often relies on trusts upgrading to the latest versions. And we know there are some trusts that are still on versions that are 10 years old. So even if we work with them and got some update done, if you aren't updating your system, that's not going to feed through to yourself. So it's quite a complex issue, but it's certainly one from a patient safety perspective that I'm pushing with my digital colleagues.
Thank you. And then there was just a question, I think, in your presentation, you mentioned safety flash, and there's just a colleague asking what safety flash is.
So a safety flash is just a messaging or a way that the Royal College of Emergency Medicine share a key safety message with their members. So they will do a safety flash, and that'll go out to their members. So it'll go to all the ED departments to say this is an important safety information. If you can find the link to the one I was talking about, I'll shove that in the chat, or I'll put it in the question answer if I can, and I'll try and answer anything else that is on there whilst the next speakers are speaking.
Yes, that'd be great. Yeah, I think there's only probably a couple more questions that if you could answer, if not now, then later. And I'll hand over to Ho-Yan for our next speaker.
Okay, Sarah, can I have the next slide, please? Thank you. Thanks, everybody. I hope you've enjoyed the session so far. Thank you for the audience that have already interacted with us. I think a good number of the audience today come from frontline services, and I think that all, if not all, would have be involved in dispensing controlled drugs and will be familiar with the controlled drug register. So the second half of the session today will be a real treat for organizations that are thinking about digitalizing their registers. So I'll hand over to our two speakers. We've got David Skiro, lead pharmacist EPMA, and Kieran Channa, operational head of pharmacy, and they're both from the Royal United Hospitals in Bath. Thank you.
Thank you, Ho-Yan. So we're going to run through our controlled drugs register. It's a bit of a journey, so we're partway through, so we can go through where we're at now, our next steps, and maybe some of the kind of learning that we've taken along the way. Next slide, please. Thank you. So just to give a bit of an overview, so we'll give an overview of the system, we'll talk through some key stakeholders, I'll do a little bit about the data, and then David will probably do the more exciting bit where he'll demo some of the system and then talk through our internal go live, some of the lessons that we took from our processes, and actually if we did it differently, what would we do different next time, and then next steps, and then we'll try and run through any questions if there's some time. Next slide, please. So bit of a broad overview. So essentially, we all know that CD Register is really comprehensive database that basically catalogues and tracks all our CDs. And when it's described in this way, you would imagine an electronic database, but unfortunately, most of us are used to the clunky charts that we keep in our dispensaries, and it's not always an efficient way. What we know is actually at ward level, you know, those processes are really difficult to adhere to some extent. Some of our nursing colleagues will sometimes it's difficult to get your drug on the right page. Sometimes you receive the drug, then you realise it's in the wrong register. It should be in the patient's own register, and it leads to lots of inefficiencies in the way that we're doing things. In addition, our paper processes are technically flawed. You know, they don't provide a robust audit trail. There's a lot of waste associated with paper itself. So I guess we wanted to consider a bit of a scoping exercise of where the waste occurs, and how we could improve that, and in addition look at our audit trails overall that we've got across our hospital and how we could improve that so it's a bit more robust. There was a business case worked up to identify some of the areas for improvement, so we split those into kind of quantitative and qualitative gains. So some of this meant, you know, we've got some cash releasing savings, and some of it was time back to care. So actually it gives our nurses more efficient ways of doing things and therefore able to spend more time looking after their patients. So the CD register has been implemented internally in pharmacy, which means we can improve our processes, iron out any issues internally first, and then start looking at the audit trail and how it's interacting with our teams, and just think about any lessons that we can take away now so that before we roll out wider, we can understand what we need to think about. Next slide, please. So a big thing was actually this can't be a pharmacy project. We have to engage other teams, and one of the biggest things is engaging those teams early. So ensuring that actually you're engaging nursing teams and understanding from their perspective how this fits, and it means that actually what you end up on is a bit of a journey and everybody comes with you rather than kind of going backwards and trying to explain what you're trying to do later on once it's all been approved. So I think that's really important. Learning and development. So part of this will form some of our essential learning for our nursing teams, and that will mean getting staff engagement, manager engagement, and releasing a bit of time to enable staff to undertake some of that learning. So it's really important that there's a really clear and easy mechanism that can be used. So for us, we're using our mandatory training portal where we're going to be able to upload some videos and enable a similar learning environment that everybody's already used to make it really easy and efficient. ICT obviously need to support us with infrastructure. We're really lucky. David, who's going to be talking later, has a lot of knowledge in this area, so it really helps having someone that's really knowledgeable in this space and how things interact and need to move around the system. It's really useful to have that from the outset. And again, divisional support. So I can't understate how useful it's been to have teams that can then go and cascade messages across and work with you to kind of send the message out there. Obviously, you need the cash. You need to be able to show how you're improving the system, and actually having that engagement from the outset is useful. And then obviously governance, the governance team. So obviously some of this is about reducing risk, about improving our processes, audit trails, all of that stuff that goes with it. Next slide, please. So I included this picture because I thought it was just really useful to show actually this is what our CD register looked like before. So when you dispense a drug, you need to find the right register, then you need to find the right page, then you need to transcribe it from the system into the drug book, and it takes a lot of time and it's really clunky. And then the next person comes along to dispense something and then they look at it and they're like, is that a 5 or is that a 3? Is that an 8 or is it a 6? So it's not really that efficient, and sometimes it means you spend time or waste time deciphering handwriting and what is essentially transcription of data. And it means our trackability isn't perfect. Sometimes the signatures aren't always present, or actually when they are, you can't always attribute it to someone, because even my signature changes towards the end of the day because I'm doing it quicker or it's slightly different or written at a different angle. So it's not always the most robust way of doing things, and it's not always traceable. And then in terms of nursing time, you know, it takes time to do daily CD checks. It takes time to write up the receipt of a medication. It takes time to administer those medicines, and writing all of that stuff out, it takes time. We're on ePrescribing as well within the trust, so it means actually being able to either bring the book to a computer where you can see the patient's information in the drug chart, or bring in a computer to the CD register, so that again it brings another step in the process. And then just the physical assets. So all of these registered need to be stored for 5 years after they've been finished with from the date of the last entry, which means they need to be put somewhere, and someone needs to find space for those. And also they take up space in the CD cupboard, they take up space in our dispensary areas, and having freed all of this up and out of our dispensary, it is now there's a lot more space to do dispensing and keeping our space a bit more tidier. It's really nice. And then we've got the CD requisition books as well, so where people are ordering their drugs, that is also paper and books, and it costs money to have all of that stuff as well. And then actually receiving the medicines on the ward, so then we have books to sign to say we're receiving those drugs as well. And like I said, those signatures don't always tell you who received the drug, because sometimes people look at them and I'm not sure who that is. Next slide, please. I think it passes over to David. Thank you.
Yes, thank you, Kieran. So what I'm going to do now is I've got a brief video which I'm going to talk over the top of, which is going to just show some of the basic functionality that we've got within our electronic system. We're going to show you how we received an order from our suppliers, how we make a supply to the wards when they've requested it, and then a little bit of how the wards will sort of receipt that into their registers. We're not live out on our wards at the moment. We're just live internal to pharmacy. So the latter part of what we'll show you is what's to come for us more than anything else. But it gives you an idea of how really the system differs from a paper registers, where you're, as Kieran has said, you're leafing through large registers looking for specific pages, often duplicating entries because you're having to write things multiple times in multiple spaces. And the electronic systems, by and large, because they're a database type based system, are much easier to do. So Sarah, do you think you could play the video for us and I'll talk over the top? So this is our system as a whole. So what we're going to show you is how we receipt from a supplier. So we have a receipt from supplier idea. Our suppliers are all built out, so you would select where it comes from. Our order reference number typically will be used here. So, and this may be multiple items on this order reference. So whereas on a paper register, you would be making an entry in each individual register for your receipts. What you can do is you basically are receipting in order. So any orders that are controlled within that order, you can enter in a single transaction. So what we're recording here is what we've requested and received from our suppliers. We're doing balances, and we've set our system to require blind balances. It doesn't give you a proposed new balance. It forces a count for the majority of items. Some liquids we've given a projected balance for low schedules, but typically we require a blind count, which helps with some of your governance issues around diversion, because obviously if a blind count's being done every time, then that helps ensure that your records should be up to date. And just as a demonstration, if the blind count is not what the system's expecting, it does highlight and ask you to sort of prompt you to recount. So that highlighted red item there. We record our batches within the system as well in the way that we would have done on paper, and we and expiries as well, and that's all traceable and trackable. Entries are made. They are double signature entries are required for the majority of actions within the system, but they don't need to be done at the same single time. So here, the entry is being made. You have the ability to countersign, but actually the system will allow a single person to make an entry, but then there's a pending countersign list that can be gone to for that countersigning to sort of confirm that the entry has been made. So you don't have to have two people in your control drugs room to make these kind of entries. It can be done at a later date. So that's essentially a basic receipt. It's much quicker than making multiple entries. You are making a single entry per enters. Now this is how we would do a request out to a ward. So in this case, our reference number would typically be the seal number of the bag that we're about to send out. And when we come to the receipt on the ward, you'll see why that we're using the bag seal. But essentially, we've had a receipt from a ward for a request. Drugs are built as a drop down, the amount they've requested, you add in, and again, a blind count is being requested here. You'll notice that we've put in a balance which is not correct, and it's highlighted it as red, but I've not noticed it as I'm going in to make this entry now. And so as I go in and make that entry and try and sign it, the system does tell me that this isn't what it's expected the balance to be, so I can go back and then recount and make a second entry. I've counted correctly this time and it allowed me to sign. If I was to proceed beyond that value, then I would actually create a discrepancy report, which the system would then flag, and our governance and dispensary team can then go and investigate that discrepancy. And here is how our countersign works. So you go in and a second person countersigning that entry will then be doing this. Typically this will be done when they're checking the controlled drug orders before they're sent out to the ward. And that clears our countersign limits. Then you can see the two people are recorded in the entry. You get a recent transactions, but you can report all those on a single drug level if need be. Now, in our test system, so we're now going to, this is how the ward would receipt it. You can see that their stock checks have been recorded previously over the last night. They're clicking on their pending item in and they can see the bag seal number. So the nurse is checking the bag as they receive it, can say, oh, this is the sealed bag. This is what I'm expecting in there. They can do their blind check and their blind balance. And then they can enter batch and expiry, although it's not required at the moment for our nursing teams to require that. And they would then put their using their individual person, and then a second person would need to verify the order receipt at a ward level. Now, maybe the second person isn't available, then they would have to go and get someone. But if they try and put their entry in twice, then obviously the system doesn't require, you need a different user to be countersigning, as you'd expect from an electronic system. You can't fudge someone's signature. These username and passwords are linked to our system IT accounts, our AD accounts within our IT system. And then you can see we've second checked it, and that shows that their balance has come in. So the issue to patients is very, very similar, and we haven't got a video of that yet because we're not live on our wards, but that's similar to the way the stock out is. So you select a patient, it's linked, the system is linked to our EPR system. So the list of patients is available in the system, searchable by hospital number or NHS number. The nurses pull that up and they can administer a dose to that specific patient. We can manage patients' own drugs within the register as well. And then the patient's own drug register will transfer with the patients as they move through the hospital. So just a brief overview of how the system works for us and how it looks. It's really nice and straightforward. It's clear and easy to see, and we're really pleased with the way it looks. This is going to really help, we think, with when we roll out to our nursing staff. Internally, our colleagues who are using it in pharmacy find it very straightforward to use. It's not lots of small windows and characters. There's not lots of complexity about it. It makes sense sort of explicitly and implicitly as part of how a register works. Okay, Sarah, do you want to move on to the next slide? So this is our CD room now. So we've actually, so the bench that you can see on the left hand side of the second computer is where basically was taken up entirely by our controlled drugs registers. So we've managed to get rid of more or less a bench worth, or get back a bench worth of space. We've put a second computer in into the CD room, which is where our teams can then check and from, so our pharmacy and technicians who are checking orders for entry out or checking orders for receipt in have got some additional working space, which we've privileged to have quite a large room for our controlled drugs, but it still felt cramped at times, and so that's been really useful. So the steps we had to go through really before we went live is obviously you take the product and then it has to be configured. So we needed to configure our system parameters, which includes our drug identities, linked to DMD drug identities, user roles and permissions for those user roles. So you can have multiple different roles depending on your staff's type. So roles for nursing, pharmacy, pharmacists versus pharmacy technicians, and then some admin roles as well. We had to set up some interfaces for patient details from the ADT interfaces from our EPR system and also to our AD login. And that was a little bit tricky, required a little bit of testing to do, but working well or having good close contact with our IT teams and the interface teams of IT was really helpful from that perspective. And I would definitely say you need that kind of interface with your ADT, because otherwise when your nursing staff are looking for patients, you do not want them to be manually entering patient details. You want it to be searchable and finding full patient details with some kind of identifying number. Hospital number typically would be ideal. We delivered staff training face-to-face for our staff in pharmacy, partly because it was the easiest way to deliver it to our pharmacy staff. We had good control over our numbers and we could release them internally. But as Kieran mentioned, we are looking at creating videos and e-learning packages for our rollout to the ward areas. We cannot train face-to-face, 2,500 nursing staff and associated healthcare professionals, and so we're going to do an e-learning route. Thankfully, the system is intuitive enough where that's something that we think they'll manage well, and we sort of targeted about an 80% of staff trained internally before we went live. This is a statutory type thing. Everyone needs to know what they're doing. There can be no excuses that I didn't want to make a controlled drugs entry because I didn't know how the register worked. So you will need some assurance that that's the case, and tracking it through our internally learning portal will allow us to do that, we think. Live testing was completed. We did a stock check and a transcription of our paper registers. This wasn't something I was particularly looking forward to because we didn't really know how long it would take, but actually we managed to transcribe our entire controlled drugs registers in about 3 hours overnight, at the end of the day prior to go live the next day. We opted to do a stock count at the same time as before transcription, so that our registers or our values were as up to date and as correct as we could be. And we did that in the evening between going end of play the day before go live, and then we went live the next morning, so to speak. So we did have no overlap. We went straight to the electronic registers. And internally we supported that, so we had some support from our supplier who provided support on the day of go live on site, and then we had support from my team, from the informatics team in pharmacy, in our CD rooms and in the dispensaries on the day of, and actually for the remaining of that week. We went live on a Tuesday and the remaining of that week, but actually practically we really had very few queries from the day-to-day after about the first day or two. Most people, once they'd interacted it initially, particularly the technical teams and the assistants who are doing the bulk of the work within the registers and the CD room, took to it really very well. We didn't have any particular issues, teething troubles, the odd things that happen every now and again that don't happen very frequently, just needed a little bit of a reminder, but generally went very well. Next slide, please. So, lessons learned, we got some good feedback from our staff. They're broadly positive. There was 1 or 2 things that they came back to us with that actually we've looked at, and we've sort of widened some of the access to some of our teams. They liked the way that you could make multiple entries at the same time. You weren't constantly having to go, if you had an order receipt, for example, from a supplier with 5 or 6 items on it, you weren't having to go find and make a separate entry with the supply details, the order number, every single drug. You can do that in a single step. It's been really useful to know that you can now access that register and make that countersign from multiple different places. The system does prevent access to the same record consecutively or concurrently rather, but for countersigning TTA, CD orders and things, that can be done from multiple sites. The system can be installed on multiple computers, and so it's been really helpful to know that if you're checking the dispensary, particularly for when we're checking outpatient or TTA items, the team do not have to go into the controlled drug room to find the registers to check the entry. And we know that entries probably weren't checked on discharge prescriptions as they should be, because it was very difficult to do and required you taking your time out and moving towards where our controlled drug registers were. It's easy to check as well for the teams dispensing that they've made an entry. If they're distracted or they have to break off in the middle of an action, they can just easily at a glance see what the last entries they made, rather than having to then think, oh, which register was I in, and that kind of thing. So there are some positive benefits there. Some of the things that we perhaps got back from us that we didn't know, which we didn't think about, is new additions to the system when patients don't register for whatever reason, and we've widened that access out to some more groups of staff now, so that they can do those actions themselves with some more training. Because if the new drug needs to be added, whereas on a paper register you just find a new page and write the description in, now it has to be added into the system as part of a housekeeping. So one of the first things I would say, lessons learned, is understand your process. Where do your things happen? Where do your entries get made? How do they get made? Is it a continuous process? If your team are dispensing, do they make entries at every time they make a book out stock to a ward? Are they making an entry at the end of a session? How is that working? Is it different people? Is it separate individuals who are doing it? When you're dispensing and checking, how does that work? Because that will have a benefit into how you train your staff and also how you configure your system. Give yourself enough time for training. It took us longer to train our staff than we thought it might do, and we had to do multiple sessions for some staff to get their heads around the concept of this is electronic and it's not paper, and how's it going to work. But with time and with the support, everyone felt comfortable before we went live, which was really, really helpful, because it was then well taken when we did go live. Plan who's going to be doing your housekeeping tasks. Is it going to be your dispensary staff? Is it going to be your back office or your informatics teams? Is it going to be your purchasing distribution teams? And how are you going to control that, and how are you going to make sure that things get added when they need to be added, and subsequently things don't get added if they don't need to be added? And then finally, access and logins, I think, was our other big takeaway. And prior to going live to the wards, it's probably the one that we are working on most from my perspective, from the IT side of things, is that we have to, we link to our AD system, so our staff logged in and got automatically assigned an account, but we need to work out a way of automatically assigning specific roles, particularly to our nursing teams and to our medical teams, because again, the large number of staff that are going to need to use the system, we need to be making sure that we're not having to manually assign roles to users and individuals as they onboard. Even though we're looking at a phased rollout, that will be quite a challenging thing to do. So next slide, please. So our next steps, staff training, as we say, probably the biggest thing that we need to work on now prior to our rollout. We're putting together some e-learning packages with our Learn Together team, particularly running as videos and sort of practical demonstrations rather than just text-based. We're planning to do this as a phased rollout. We're planning to do it looking at our nursing teams on the wards and how we can support them and make sure they're appropriately trained. Thankfully, it is able to do this so that we can sort of do ward by ward or several wards at a time. How long that's going to take us, we've yet to really decide, and we're also competing with a few other projects happening in the trust at the moment, so we're just sort of arranging around that. And then, finally measuring our success. We've got some baseline data in pharmacy. We need baseline data from the rest of the team, but how do we go on from there? Okay, I think that might be our last slide. It is. Thank you.
Thank you very much, David. Thank you very much, Kieran, for coming to present to us. I found it quite insightful and I've learned loads, especially that video was really, really great. We've had loads of questions from the audience. If I didn't have enough time, well, we're gonna run out of time with the questions. Will you be happy to take the question offline and answer them after the session? Yeah, okay, that's great. I think 2 questions that I did want to pick out is something about interoperability. Would you be able to scan your products in when they come into the department? So at the time of receipt?
So at the moment we don't, but in theory, yes. So the next stage from our supplier is that actually it will integrate with our stock control system. And so at that point, when we receipt and book into our stock control system, it will make a prospective entry into our registers that needs to be countersigned and sort of countered. And at that point, you don't need to scan the products into the system. They will be entered in when you scan them into our stock control system. But in principle, yes, you could scan them, and there is some barcoding functionality in there, although the way we intend to use it eventually, it will be linked to our stock control system, so that as we book out or receipt, then we will get an incoming entry, if you like, into the registers for us to countersign or review, enter more details, and then countersign. So barcode scanning will then work, but not necessarily in the way that I suspect the question asks.
Yeah. Okay, thank you, David. I think the next question that I wanted to propose is around any new risks. So we obviously went from a paper system to a digital systems. Have you identified any risks by changing the way we record things?
I think the biggest risk probably is probably access to the system. As we go wider, it's easy to control within a single department. As you go wider out, you need to make sure all of your clinical staff have access to the system to use it. It's much harder with this system to fudge it. So in terms of fake fudged entries or times, everything will get a timestamp, everyone will get an electronic signature as alike, so that's much easier to control. But I think our main worry is really, as we roll this out, everyone will need to be au fait with it and using it, and that's probably the biggest risk. A paper register, although clunky, is something that since time immemorial our staff have used and are very, very familiar with it. They may not enjoy the experience, but they are familiar and can do it. And there is a risk when you move to anything electronic that you alienate, or you sort of silo off a certain group of staff who are not comfortable with that kind of electronic system.
Okay. That makes sense. Okay, then the last question before I finish the session is with regards to, and I think this might be because on our last session we talked about BCP. So what happens when your e-register goes down?
So we have an offline. There is actually, as part of the system, there is an offline downtime viewer that we can look at. So basically, the system I think it's about every 5 minutes, it takes a offline copy, mirrored copy, into a file server that is not part of the system itself, off the server, and that's accessible from our intranet, from a web link, which is accessible. Now, if we were to have a sudden complete loss of functionality, then obviously we have got downtime procedures in place to do that. But if it's a temporary loss of the electronic register itself, then there's a downtime accessible, basically a copy of what the current balance is for all drugs in all the different areas, so you can continue business continuity be carried forward. Obviously, if you lose your entire network and everything else, then that doesn't work, and so we do have downtime procedures from there on in. But obviously a total network loss is a fairly major thing, which thankfully, touching some wood, we haven't had with any of our electronic systems as yet.
Well, it's something to think about. Yeah, brilliant. Thank you very much. Thank you for your speakers. Thank you everybody who asked questions. Sarah, could I have the next slide, please? Thank you very much. So I've really enjoyed the session today, not just the last session, but also Paul and Graham. I hope everybody had some takeaways that they can take back to the trust and some learning. As mentioned before, the certificates and recording will be emailed out to you. And then just a little promo for our next masterclass, which is on Wednesday, the 5th of June, similar time. And we've got the Somerset team coming to present to us about the One Shared Care Record. We've got Sandeep coming to present to us about burnout in pharmacy, and also we've got a speaker from the Shuri Network who will do a little talk about the Shuri Fellowship. Amna, have you got any last remarks?
No, just if anyone does have any future topics, feedback or volunteers, just please get in touch with Sarah, because we always welcome speakers to the event. It makes it more tailored to the audience of what you're wanting. Thanks, everyone.
Yeah, enjoy the rest of your day, and thanks for joining.
Bye.
Bye.
Bye. Thank you.
Thank you. Bye-bye.
You.